Welcome to this explainer, where we're going to completely unpack the clinical dossier of the Nocardia brain abscess. If you want a comprehensive, textbook-level understanding of this highly specific and, frankly, very dangerous invader, you're in exactly the right place. We're going to break down every single crucial detail from our source material point by point, so you don't even have to open the book to know exactly how this pathogen operates. Let's get into it. All right, here is our roadmap. We'll start by profiling the pathogen, then identifying high-risk patients. From there, we'll track its CNS involvement, confirm the diagnosis, look at primary antibiotic protocols, and finally, go over surgical and long-term care.
Section 1. Profiling the pathogen.
So right out of the gate, we have to clear up a massive misconception. Because of its branching appearance, it is incredibly easy to mistake this organism for a fungus. But it's not. No way. Nocardia is an obligate aerobic actinomycete. That means it is strictly a bacteria. Keeping this foundational biological classification in mind is absolutely crucial for everything we're about to discuss.
And understanding its origin story is really the key here. Nocardia asteroides is a gram-positive beaded branching bacillus. It's a soil-borne obligate aerobe, meaning it lives in the dirt and it absolutely requires oxygen to survive. Usually, a patient gets inoculated simply by breathing it in through the respiratory tract. And from the lungs, it sets the stage, going on to produce either a localized or a completely disseminated infection. Now, to put the scale of this threat into perspective, Nocardia is responsible for precisely 2% of all brain abscesses across the board. Just 2%. But within that slice, the vast majority of those infections are driven specifically by the exact species we just profiled, Nocardia asteroides.
Section 2. Identifying high-risk patients.
Nocardiosis doesn't just strike randomly. It preys on patients suffering from specific chronic debilitating illnesses. There are 6 main profiles you really need to watch for. First, patients with neoplasms, specifically leukemia or lymphoma. Second, anyone with conditions that require long-term corticosteroid treatment. Third, Cushing's disease. Fourth, Paget's disease of bone. Fifth, AIDS. And sixth, renal or cardiac organ transplant recipients. So whenever you have a high-risk patient from this exact list who presents with soft tissue abscesses alongside CNS lesions, this precise culprit has to immediately jump right to the top of your suspect list.
Section 3. Tracking CNS involvement.
Okay, so how does a soil bacteria end up in the brain? The answer is hematogenous spread. It basically hijacks the patient's bloodstream. After being inhaled into the respiratory tract, the infection travels through the blood. This frequently results in cutaneous or skin lesions, right alongside its eventual CNS involvement. It's essentially planting infectious seeds in multiple systems all at the same time. And this fraction is a clinical pearl you'll definitely want to lock away. Central nervous system involvement occurs in about 1/3 of all those high-risk patients we just talked about. 1 in 3. Now, when it actually does breach the CNS, it's going to leave behind one of 4 specific types of damage. It can manifest as a cerebral abscess, it can cause meningitis, it can result in ventriculitis, which is particularly common in patients who have a CSF shunt in place, or it can present as epidural spinal cord compression, which actually stems from vertebral osteomyelitis. Let's zero in on that first manifestation for a second. If you're looking at an MRI of a suspected Nocardia cerebral abscess, you're hunting for 2 defining physical signatures. These abscesses are very often multiloculated, meaning they have multiple small cavities or chambers inside them, and they are going to demonstrate restricted diffusion on the MRI scan.
Section 4. Confirming the diagnosis.
Listen, do not waste precious time with blood serum antibody tests. Serologic tests for Nocardia are completely unreliable. You just cannot depend on them to make this diagnosis.
Instead, the absolute most sensitive test at your disposal is the classic gram stain of the specimens. When you use a gram stain, you're going to physically see those characteristic gram-positive beaded branching filaments. Plus, it's worth noting that these specimens will only weakly stain in acid-fast preparations.
So, how does this diagnostic logic apply when it comes to invasive procedures, like a brain biopsy? Well, generally speaking, a brain biopsy actually might not be needed in these high-risk patients if a Nocardia infection has already been confirmed in other sites on their body. However, and this is a massive exception, you still need a biopsy in AIDS patients. Why? because they carry a very high, considerable risk of harboring multiple organism infections simultaneously, or an infection plus a tumor, particularly lymphoma. You literally cannot just assume the brain lesion is solely nocardia without actually checking.
Section 5. Primary antibiotic protocols. Right before we get into the drugs, let's have a quick word on surgery. From a purely surgical perspective, the indications for operating on a nocardia brain abscess are exactly the same as the standard indications for any other type of brain abscess. The rules of engagement in the OR just don't change for this specific bacteria. All right, on to pharmacotherapy. Here are your precise antibiotic choices. Your primary attack is trimethoprim sulfamethoxazole, or TMP-SMZ. That's given at 15 milligrams per kilogram IV of the trimethoprim component per day, and you're going to spread that out into 2 to 4 divided doses. But you don't use it alone. You use it plus imipenem at 500 milligrams IV every 6 hours. Furthermore, if you're dealing with CNS disease that has multi-organ involvement, you might also add amikacin at 7.5 milligrams per kilogram IV every 12 hours. Now, what if your patient has a sulfa allergen and simply can't take TMP-SMZ? Your alternative regimen is imipenem at 500 milligrams IV every 6 hours, plus amikacin at 7.5 milligrams per kilogram IV every 12 hours.
And because this pathogen is incredibly resilient and adaptable, it is absolutely mandatory that antimicrobial susceptibility testing be conducted on all isolated samples. You have to prove in the lab that your chosen drugs are actually capable of killing the exact isolate that's attacking your patient.
Section 6. Surgical and long-term care.
When there's CNS involvement, this is a long haul. You must maintain this treatment for a minimum of 1 year. Let me emphasize that. At least 1 full year of treatment. And if you're dealing with an immunocompromised host, this treatment might actually have to continue indefinitely. The reason is that the risks of a relapse or further hematogenous spread are simply too severe to risk stopping the antibiotics. We've completely broken down this clinical dossier point by point, covering every single vital detail from the source materials so you have a complete picture. We've tracked this thing from the dirt to the lungs, through the blood, and right into the brain. We know its disguises, its targets, and exactly which chemical weapons will destroy it. So I'm going to leave you with one final thought. Now that you know its exact clinical signature, how quickly will you spot this invisible invader before it takes hold in your next vulnerable patient? Keep these concepts fresh, and you'll be ready for it.